Good morning. I think very few people, it's actually a good thing to have. You can all come a little forward so that we can have a smaller group right in front so we can have a more informal discussion. So this is a interactive session on refraction. All of the lectures in the rest of the day will be more didactic. So this is one session which lasts for 60 minutes, will be on the basics as Madam told, and a very important aspect of refraction. Refraction obviously is important for two reasons. One is for the exams. So let's face it. The examiners know definitely more refraction than you people. So obviously you need to know something to pass the exam. And more importantly, after exams, okay, if your autorefractometer is not working, the optometrist is not behaving properly or working well, so you will be stuck. Every subspecialty in ophthalmology is linked one way or the other to refraction. So you should have some basic tenets of refraction, okay, as your strong point so that you can actually have a good practice. And very paradoxically, even the patients think that the refraction is very easy. It's not the case. If you give wrong glasses, the patient thinks, usko glass dena bhi nahi aata, wo cataract surgery kya karega? So obviously don't expect a patient to come to you for a cataract surgery or any other surgery, okay, if you are given the wrong glasses in the beginning. So make sure that your refraction, okay, builds you takes you to a good practice in future. So let's basically start with, I have a small writing device. So if there will be some amount of interaction, and please feel free to answer. Okay, you can be wrong. I'm going to ask you questions, you can answer me, and that's how this thing go on. In 1 hour, we'll try to finish some basics and some of the applied, or the clinical optics and refraction to the extent possible. So let's start with, refractive errors. Very obvious, they will ask you myopia, hypermetropia, and astigmatism. So what's myopia? When a parallel rays of light, okay, enter the eye, they focus in front of the retina. So that's myopia. What are the types? Somebody, you can just shout it out. Index myopia. See, okay, this is something that's very important. In refraction, in any viva for that matter, the latency matters a lot. If you want to get good marks or pass the exam, make sure that your answer is immediate, fatafat. Because the examiner thinks if you take 5 seconds to answer a very basic, okay, silly question in refraction, okay, they will start doubting your integrity. Okay, make sure certain things come immediately, like a bullet. And when you say types of refraction, when you say index myopia, that says that probably you don't know what is myopia. In practice, it's very rare to get an index myopia. It's more commonly axial myopia. So obviously, you have to tell the most common things first. That is the basics of, why we're answering. So first, you always say axial myopia, then curvature myopia, index. Then we have one example. Axial myopia is where the eyeball is bigger, okay, because of the increased growth or because of some ectasia or because of some collagen problem. And curvature is example of curvature myopia. Keratoconus, okay, which is very classical cause of curvature myopia. Index myopia, somebody said, index myopia is as a hardening of lens because of the natural changes in the lens due to age. Lenticular sclerosis causes a change in the refractive index of the lens, causing index myopia. Similarly for hypermetropia, okay, where the parallel beam of light rays focus behind the retina. So again, axial hypermetropia because of the small size of the eye. Then curvature hypermetropia. Anybody give an example? Cornea plana, okay. So where cornea is very flat, so you get, what is index hypermetropia? So for example, a patient today comes to you with 6/6 vision, okay, you give him near glasses and send him. After 6 months, suddenly he rushes to your clinic. He says, suddenly, I can't see anything, doctor. You find his AR and you do plus 1.5, he is again reading 6/6. He had no hypermetropia 6 months back, but today he has developed acute hypermetropia. How is that possible? How is that possible? It's very common in practice. Then you have to check your blood sugar. So glycemic fluctuations drive the eye mostly to hyperopia. Okay, this you should understand. If there's a lenticular sclerosis, it leads to myopia, but sometimes you just check his blood sugar, it's fluctuating heavily, so you have to put get back normoglycemia and then recheck, this hyperopia will disappear. Okay, so this is an example for index hyperopia. Next comes astigmatism. This becomes a little more complicated. Now, astigmatism is a situation. See, there are no definitions in the book. You can make your own definitions. You have to basically understand what is just a simple English. So, astigmatism is a situation where the two meridia, okay, the refraction to the two meridia are unequal. So, instead of having one focal point, you will have two focal lines. Okay, and these two meridia are usually perpendicular to each other. So, you have, what are the two common types of astigmatism? With the rule, against the rule. What is with the rule? Which is steeper? Okay, this should be in less than half a second. The answer should be, because these questions are, cannot be, you can't take more time. Even though you know the correct answer, taking more time is not answering it. Okay, so with the rule is vertical steeper, horizontal is steeper, against the rule. What is the most common astigmatism that you get during a cataract surgery age group? If you are doing a keratometries, it is against the rule. Normally, during young age, it is with the rule, then it shifts to against the rule. This is very, very important. So, all your cataract surgery people will have a horizontal as steeper and vertical as a flatter astigmatism. Similarly, you can also, go further on into what is called an oblique astigmatism. What is oblique astigmatism? Oblique astigmatism is one where the two meridia are perpendicular to each other, but they are not 90 and 180. Okay, with the rule, against rule, it's usually 90 and 180, vertical and horizontal. Whereas in oblique astigmatism, they may be 45, 135, 30, 120. They are perpendicular, but it's not 90 and 180. Whereas bioblique is further next. The two meridia are not 90, 180, and they are not perpendicular. For example, if one is 30, okay, other should be 120, but it will be 140. So that is called as a bioblique astigmatism. So this is a very important thing because astigmatism is a major cause of visual morbidity and deterioration of vision, and this is an important aspect of ophthalmic surgery for the years to come. And next is, we basically classify astigmatism depending upon, okay, how are these focal lines situated. Okay, you basically classify them into simple, compound, and mixed astigmatism. Okay, so there are again simple myopic and simple hyperopic. So now I'm going to ask you a question. I want you to answer in 2 seconds. Anything more than 2 seconds is as if you have not answered it. Okay, now give me an example for a simple myopic astigmatism. 2 seconds over. Madam, you are the timekeeper. Simple myopic astigmatism. Any minus sign, any damn number, any damn axis. Don't tell same thing, but you write -2. Sorry. So don't try to conjure up something taking a lot of time. There's nothing there. No, you don't have to fabricate anything. See, -1 cylinder at 180, 90, 45, whatever. So simple hyperopic. So plus any damn number, any damn axis. So now compound myopic astigmatism. Compound myopic. Both the focal lines are myopic, both are in front of the retina. So -1 sphere, -1 cylinder at 180 degrees. See, how you write is also important. You may have various different connotations. Make sure when you write a prescription on the paper in the exam, you should be very legible, write bigger letters, write capital letters, and have see, for example, -1.0. Don't write just only 1. And write capital D. Okay. Some people write S, indicating spherical, or SPH, whatever, slash, -1, 0, D, C, or CYL, whatever. Okay, into, at, whatever. Okay. 180, whatever. Okay, 90s, some number. So this is simple. So if this becomes plus and plus, it becomes a compound myopic astigmatism. So now I'm going to write an example. Please tell me what is this astigmatism. Okay, quickly. I'll give you 4 seconds. Okay, +3. There's a mixed opinion. How many say mixed? Okay, quite a strong lobby for mixed. So this is the hitch. When a mixed astigmatism is 1, the cylinder power is always more than the sphere. Can somebody transpose this? This is plus 3 anyway. So if you transpose, this is plus, this is plus. Okay, if you transpose this, how do you transpose? Take the algebraic sum of the sphere and cylinder. What is the algebraic sum? Plus 3 minus 2 is how much? Plus 1. So it is plus 1. And change the sign of the cylinder. So it becomes plus 2. And the 90 becomes 180. So it is 180. So what is this astigmatism? It's a compound hyperopic astigmatism. So whenever you have a cylinder which is less than the sphere, it is not a mixed astigmatism, it is a compound astigmatism. So this is something that you have to know. Okay, this is important. So friends, somebody give you another example for a mixed astigmatism, quickly. Anything. So any damn number, okay, and any other damn number which is more than the first number, okay, like minus 2, any damn axis, okay. So this is a mixed astigmatism. So this is how you basically have to understand. So now comes, see, I always keep telling people that we are all very fortunate to be in ophthalmology. If somebody is regretting their decision that having come to ophthalmology, okay, be rest assured wrong. There are many specialities, but ophthalmology is one where you are all fortunate to be in. Because the ophthalmology is now in a boom. And the next boom yet to come. Cataract, okay, retina are the booms that we have experienced. Refractive surgery. Now what is the next boom? So you should be ready for that. What is the next boom in ophthalmology? See, that is for you. That boom we will be over, but that basically is waiting for you to come in, step into the field. See, the next boom is a condition which is universal. Everybody should get it. See, why Bill Gates made more money? Because he uses, he has made a thing which is used by all. So similarly, some disease which is probably affects all will be the boom. So what is the next boom which affects all at age of 40 years? Presbyopia. So presbyopia will be the next boom. So be ready to correct presbyopia, not with glasses, something other than glasses. Okay, so you should understand presbyopia for the exam and for the boom that you are waiting for. So let's start with presbyopia. How do you define presbyopia? Just tell me, how do you define presbyopia? It should take only 2 seconds. Huh? So it's a condition, age-related physiological condition, in which there is a blurring for near vision because of decrease in the amplitude of accommodation. This is your definition. It's not mine, nor in the book. So there's a problem for the near vision because of decrease in the amplitude of accommodation. Okay. Why does presbyopia comes at 40 years? My question was, why does presbyopia comes at 40 years? Why not at 30? Why not at 60? So the reason is, the presbyopia comes at 40 years because we have an elbow joint. Make sense? Imagine we did not have an elbow joint. We had one long bone like this. One bone, humerus ulna together. Okay, one bone like this. How will you hold anything? You will hold like this. You will read like this. Okay, you will work like this. So when will be the presbyopia? Maybe never, or maybe at 60, or maybe at 50. Because we have an elbow, you are just holding it like this. It's a practice. Nobody told us to do so. We are doing that. So basically, when the near point of accommodation recedes, it comes to a place we normally customarily hold things. So for the first time when somebody comes to presbyopia, just tell them that you keep it away, that's all. Okay, don't have to do anything, just keep it away, the job is over. So there's nothing magical at 40. So basically it coincides. So that's why I want to tell this, because please don't go with the idea that at 40 somebody needs glasses. Or you're putting them as old. Okay, like many people will be old then. So basically, somebody can have presbyopia at 35, at 30, at 50, at 60, depending upon where they do things. How much is their amplitude of accommodation? Right? So it is nothing about age. So never prescribe presbyopic correction with age as the criteria. Never. Everybody is different. Everybody's working distance is different. So this is something that you have to know. So now they will ask you, what is near point of accommodation? So near point of accommodation is 1. Okay, it's a point closest to the eye that can be seen clearly by maximally exercising accommodation. So how do you check? They can see blood, this is my near point accommodation. Okay, so near point of accommodation is, it depends on the age. A child which has a very good accommodative amplitude, okay, can see very close to the eye. So how do you convert near point of accommodation using amplitude of accommodation? Okay, so or you can vice versa. You cannot measure the amplitude of accommodation with any measurement, but basically check their NPA. I mean, that is the near point of accommodation. Then convert it into amplitude. Imagine if I want you to, check my amplitude of accommodation, you have to do my NPA. NPA is 25 centimeters. If it is 25 centimeters, what is my amplitude of accommodation? Oh, this silence is very eerie, This is very, very disturbing. I told you you have to make sound. 100 by the distance, that's all. Simple. See, you're all very good in mathematics. You had always 100 in your second PUC or +2, okay, and you lost it down the line. Make sure this much of mathematics will save you through. 100 divided by the distance or NPA. 100 divided by 25, how much? 4 diopters. If I can see up to 50 centimeters, 2 diopters. If I can see up to 10 centimeters, 10 diopters. A child can see up to 7 centimeters. So it must be 14 or 15. So you have to convert that way. So whatever distance the closest to the eye, okay, that can be seen, okay, so it depends on the age. Every person, amplitude of accommodation keeps decreasing, so also the NPA recedes. Okay. So similarly, you have another definition called NPC, that is near point of convergence. So that is a point closest to the eye that can be seen as single. Okay, it becomes double, this is NPC. Okay, so what is NPC at the age of 40 years? And what is NPC at the age of 10 years? So convergence is not age related. You are born with some amount of convergence. It doesn't change with age. And NPC, you check NPA separately or with both eyes open, NPA. Near point of accommodation is checked separately for each eye or binocularly. Huh? So you have to say for the right eye, this is my NPA, for the left eye, this is my NPA. For the right eye, it is 30 centimeters, for the left eye, it may be 27 centimeters. So similarly for NPC, for right eye, left eye, how much it will be? Okay, so NPC is a binocular function. So you can't check NPC with one eye. You will never see double with one eye. So NPC is, that means in the definition you can add this. It's the point closest to eye when viewed binocularly, which is seen as single. Okay, that is NPC. How much is our normal NPC? Anywhere between 8 to 10 centimeters. You should know. Anything less than 8 to 10, you see it as double. If you've got a convergence insufficiency, you can see double much earlier. You may see at 15, 20. So you may have an inherent convergence problem, okay, and it is also linked to a refractive errors. Please understand, all these have a lot of bearing on prescription of glasses. If you find a patient is having convergence insufficiency, imagine she has minus 0.5 myopia, or another patient has convergence insufficiency minus plus 0.5 hypermetropia. Which one you treat, which one you don't treat? Which you don't treat, which you treat, if a convergence insufficiency. So whenever there is an exophoria, whenever there is a convergence insufficiency, whenever there is an intermittent divergent squint, or frank patients of exotropia, you should always adequately correct or fully correct or even overcorrect myopia. You understand? If you correct myopia, okay, then what happens? The patient will have to accommodate. If you don't correct myopia, the patient will be using his myopia correction to see. He will not, accommodation will be at rest. So you have to stimulate accommodation. So please tell in the exam, by giving a myopic correction, we are stimulating the accommodation. With accommodation comes the accommodative convergence. So what are the types of convergence quickly for you? Number one is a tonic convergence. That is, the convergence is, this convergence is the tone of the medial rectus muscle, which normally keeps the eyes straight. Normally the eyes are divergent as per the orbital axis, but that is the tonic convergence, which is not of any use, it just keeps the eye straight. Then we have the very big chunk of convergence is what is called fusional convergence, which can be strengthened with your exercises. So fusional convergence is a very important thing. If you are poor in that, you will develop convergence insufficiency, intermittent diplopia. So fusional convergence. Next is accommodative convergence. So accommodative convergence is the amount of convergence that happens whenever you accommodate. It's a synkinesis. It is a cortical phenomena. Some amount of accommodation will bring about some amount of convergence. It is fixed. Fixed as per a ratio called AC by A ratio. That means if you are accommodating one diopter, okay, then the convergence of the eye will happen anywhere between 3 to 5 prism diopters. Okay, so this 5 by 1, accommodative convergence divided by accommodation, is a ratio you are born with. If there is a discrepancy in this ratio, imagine your AC by ratio is very low, you will develop convergence insufficiency. If your AC by ratio is very high, you will develop non-refractive accommodative isotropia. Okay, non-refractive accommodative isotropia. So what are the methods by which you can measure AC by A ratio? One is, just remember, gradient method, heterophoria method. Okay, so you stimulate or you relax accommodation, check the deviation, that for one diopter, how much is the convergence that you have to measure. So, but very importantly, now in the exam they will ask you, even in the thing, I will ask you something very basic. Okay, we are all ophthalmologists of tomorrow. A patient comes, which is very common. You start a practice, a patient walks in. He says, I am 40 years, I can't see. Nothing great about it. Every alternate patient is like this. Presbyopia is the biggest chunk, I told you, the big boom. Okay, so now let us see your basics. Let us try to shake your basics. How do you prescribe glasses for this guy? Madam, tell me, a patient with fine, he's 40 years old, he says, I can't see near print. How will you prescribe him? No big deal. It's a very simple question I'm asking. Distance correction 6.6. Simple, guys. Okay, this is very important. You ask him the working distance. So please ask the first question, what is your working distance? What do you need these bloody glasses for? Computer, something, or you're the watchmaker, or is doing something like this? So what is his working distance? At what distance he's actually having a problem? So his working distance, he says, around 40 centimeters. Then, how do you prescribe? See, this is a simple thing. Every day we prescribe glasses. There must be a method. Huh? At 40 he is not able to see N8. How much? Plus 1. Plus 1 he is 6.6. He is your N6. No, plus 1 do you give him plus 1? अरे यार डिस्टेंस के लिए तो कुछ तो है ना, बट नियर के लिए क्या है? वो कैसे है? वो प्लस 1, वो ये तो बंदा प्लस 1 से भी N6 पड़ेगा, प्लस 1.5 से N6 पड़ेगा, प्लस 2 डालो तो भी N6 पड़ेगा, एंड किसने 0.75 डाला वो भी N6 पड़ता है वो. He is very full. What glasses to give him now? Correct? Any number from 0.75 to 2, he is reading N6. How much to give? Least plus. Very good. How many agree for least plus? Oh, the many. Okay. So when somebody makes a mistake, you have a big following anyway. So try to understand. Whenever he is complaining that he is seeing N8, it means to say that he is already using all his amplitude of accommodation already. उसके पास जो भी है, he is already using it. He has some accommodation left with him at this age. वो पूरा यूज करके जो नहीं दिखता है उसकी बाद तुम्हारे पास आता है. So please make sure you understand that he is already using it. For example, imagine a weightlifter. He is won a gold medal by lifting 150 kgs. उन्हें gold medal जीत लिया. Then what do you think? Oh, this man can lift 150 kgs. So you can put a 150 kgs on the head and ask him to move all throughout the day? No, he can't lift 150 kgs throughout the day. There's only one time attempt. So whenever he reads N6, imagine he's putting all his accommodation reading N6, but he can't read that the whole day. That means his full accommodation cannot be exercised the whole day. Something has to be left unused. If this guy can lift 150 kgs in a tournament, he can lift 75 kgs aram se every day. So that is what I'm saying. So please make sure some accommodations already should be relaxed. That means Whatever is reading N6, you have to slightly overcorrect. Give another 0.5 more so that this 0.5 diopters of accommodation of his own will not be used. It will be left unused, and that will also give him a range of accommodation. If you are checking at 40, giving him least, something from 40 centimeter comes to 35, he can't see. Obviously, you need a range to work. You can't always work at 40 centimeters. That means you have to leave some accommodation unused. You have to slightly overcorrect so that you give him a range. So how do we give glasses? At the same time, what if you overcorrect also? Imagine this guy required +1, somebody gave him +2.5. Okay, he's still reading N6. But what will be the problem he'll be facing? 40 centimeters से थोड़ा पीछे तो कुछ नहीं देखेगा. Because he can't, see, when you give +2.5, he's completely relaxed. He has to relax his accommodation to see that. He can't relax the accommodation beyond a point. So this is very important. You can't exercise accommodation all the time, fully. At the same time, you can't relax it beyond a point. So overcorrection, undercorrection, both give him a problem. So what we do is normally, you find out. See, there's nothing like doing with age. Never tell any examiner that age, 40 years +1. No. You have to subjectively try and to see at working distance, he is able to see clearly. It takes a lot of time to give plus glasses for near. So then what you do is, you have to do what is this checking the range of near vision. See, what you do is, at this distance, it is working distance, you have corrected him. Now bring it, 3 inches forward. He should be able to see. If he is not able to see 3 inches forward than the working distance, that means you have undercorrected him. You have to have another 0.5. Second thing, you take it backwards by another 3 or 4 inches. He should be still able to see from the working distance. If he is not able to see that, that means you have overcorrected him. Okay, so you correct in such a way that from his working distance, 3 or 4 inches behind, 3 or 4 inches in front, he should be able to see, so that there is this problem of overcorrection and undercorrection is taken care of. This is very important. Okay, there is one more complicated method which is more scientific but not followed, is you have to check his NPA. Accordingly prescribe. For example, this guy comes at 40 years, he is not able to see at 40 centimeters. Okay, you check his NPA. His NPA is 33 centimeters. Then what is his amplitude of accommodation? 3 diopters. So we decide that one third of his accommodation we are going to leave unused. So at 40 centimeters, he is going to read +1. He needs +1, so we add this +1 to that. That means we are basically trying to relax 1/3 of his normal amplitude of accommodation, keep it at rest. So if you give him +2, he'll be reading, even if it comes front, he'll be able to use that accommodation which is left unused. Only intermittently, not all the time. Okay, so this is another way. Check his NPA, find his amplitude of accommodation, take the 1/3, add it to your correction. Okay, and also see that you rather go front and back, so see that. Now, we'll come to the most important part, which makes you pass the exam. Okay, so you have seen the Jesus crucified. Okay, you see the cross. So whenever we see the cross, we remember the Jesus also in the exam. So the same state of yours. So we give a cross, ask you to write the acceptance. Okay, so now from that group, somebody will answer, this is +2, this is -1. Can you tell the acceptance, sir? First bench, this side. Acceptance, madam? It is acceptable to you? This number? Tell me. This again a 3 seconds answer. Refraction, all questions are 3 second answers, okay? Latency is maximum 3 seconds. You are out of the examination already. Okay, your next candidate has already come in. If you take so much time for a cross, okay, somebody who suddenly answers in 3 seconds are also out, because you are supposed to ask 2 questions. Okay, they want to test you. They are going to put a cross and test you. Don't be just taken away by that. You have to ask 2 questions. What are the 2 questions you ask? What is the working distance? So the distance in which this retinoscopy has been performed, it makes a big difference. Second thing, any cycloplegia. So working distance and cycloplegia, if they don't give, sometimes they don't give, they want to test you. So you always have to ask, sir, That too very, politely. You can't say, what working distance, sir? So politely, sir, can I know the working distance? Can I know the cycloplegia? Okay, I'll make it simple. This is a dry refraction. What is dry refraction? No cycloplegia. This is a 2/3 meter. Now quickly, 3 seconds. Oh, plus 0.5. Then what? Minus 3. Minus 3 at? See, we are not impressed. Definitely Dr. Vasanta is not impressed. You have taken time, almost 1 minute. See, it's very simple. If it's a dry refraction in 2/3 of a meter, see what you do is, take the plus side. Normally they give a missed astigmatism many a time. Take the plus one, or if it's a plus, take the higher plus, subtract 1.5. So plus 2 minus 1.5 will be plus 0.5. Then see the difference between the two numbers. It is actually on the algebraic scale, on a number scale, what is the difference? Like plus 2 and minus 1, what is the difference? Plus 2 is 2 times on the number scale of other side of the 0. Minus 1 is on this side. What is the difference? 3. So there will be minus 3, and this is acting at horizontal axis. So you have to put a vertical axis, give the cylinder in the 90 degrees. So you have to give it like this. So I'll just give you another thing. Two-thirds of a meter, dry diffraction. Quickly. The mathematics is very poor. Come on. Minus 2.5 diopter, sphere. Minus 1. Why 0.5? No. This is another mistake. Don't subtract 1.5 from the second meridian. The first meridian you subtract. The second meridian don't subtract. Just put the difference. You're going to subtract minus 1.5 from minus 1. So it becomes minus 2.5. What is the difference between the two? 1. So put it as a cylinder. And it is working at? So you need an axis at 90. So you have to put the cylinder at 180. So quickly again, another one. Minus 7, minus 5. Quickly. Minus 6.5, minus 2. Now again, 0, 0, minus 1, 2/3 meter. Minus 1.5. Yes. Now, you tell me this. What about this? One meter. Minus 1.5? Minus 1. So minus 1 diopter sphere, minus 0.25 cylinder at 180 degrees. So this becomes an easy thing. Now another thing, you try this. Plus 7, plus 5, working distance 2/3 meter, atropine. See, now check without atropine. Without atropine, how much it is? Plus 3.5, plus 2 at 90 degrees. Now with atropine, what changes? How much you are going to subtract? No, you subtract one more. So apart from 1.5, you are going to subtract another one. So you are going to subtract 2.5. So 5 minus 2.5 will be 2.5. So plus 2.5 sphere. And now again, don't subtract atropine from the other meridian. See, astigmatism is only the difference in the two. You don't have to do anything to the second meridian. Just put the difference. The astigmatism is the difference in the curvature. Don't give any working distance or any cycloplegia modification to the second meridian. Put the difference. The plus 2 remains, the cylinder remains, whether you put atropine or not. You understand? That can't change. So you put it as, so it will be plus 2.5 sphere, plus 2 cylinder at 90 degrees. So now comes, we are going to ask you again in the exam some transposition problems. This is something which is very, I'm sorry. Yeah, please. Sorry, come on, come again. See, whatever you do higher plus or lower plus, it doesn't make a difference. It's 2 plus 2 or it is 1 plus 3. See, it's mathematics. So similarly, I'll come to transposition. Now, this is your question will be answered in this. Now, I want somebody from the last bench to transpose this, okay? Please transpose this. Minus 1 sphere plus 3 cylinder at 135. Okay. So I'll put the transposition. What you do is you do an algebraic sum of the sphere and cylinder, that is minus 1, and change the sign, and the perpendicular to this is 135. Now you tell me which glass I have to prescribe. I have to put a minus cylinder glass or a plus cylinder glass? Minus cylinder glass. That means if you prescribe the other one, the patient will see differently. Okay, I see heads nodding. That means if I give you 2 plus 2 or if I give you 3 plus 1, will it make a difference? Boss, understand, transposition will not change the optical outcome of the glass. It is just a different connotation. Okay? Just a different, we are only trying to convert it into a negative cylinder form. Actually, transposition has no meaning in our day-to-day practice. You understand? No patient is going to feel better with your transposition. Okay? It is only a weapon in the exam. Okay? We are asking you transposition just to understand whether you know some mathematics, not for ophthalmology. Because whether I give the first prescription or the second prescription, the patient gets the same glass. The same spirocylinder toric correction he gets without, changing any outcome, because it is just a way we are writing. Whether you write the plus cylinder form or the minus cylinder form. Only thing is, why we prefer the prescriptions in the minus cylinder form is to make the optician's job easier. Because when you write, when you enter in the machine, when you grind the machines, if somebody has put a LASIK workup entry, okay, somebody is entering the LASIK data for a surgery, the machine asks always in the minus cylinder form. Even if the patient has a compound hyperopic astigmatism, okay, if you want to do a LASIK, it asks a minus cylinder form. Like with a plus 1 sphere, plus 1 cylinder at 90, this is the correction for LASIK. I have to make it as plus 2 sphere and minus 1 cylinder at 180 degrees. Because that is what the machine takes it as. So you have to convert into negative cylinder form. So even when you are grinding the glasses, the machine takes the negative cylinder form. So it is easy for you. This can be as well done by your optician. Okay. So you are doing his job. Transposition as such, in the real sense of the word, has no meaning, has no relevance to our modern day ophthalmology. Only thing is, as long as the examiners are asking this, you are supposed to know this. Please understand. So don't bother about toric transposition. I have stopped teaching that. So this is what is the transposition. Now, it is 45. What if it is 19? So again, it tests your mathematics. 109? Very good. So it took 10 seconds. I will tell you a simple way where you can answer it in 1 second. Any number. Okay. See, the clue is like this. Whatever the number is given, take the first number, split it into 1 plus the remaining number. For example, if it is 29, convert it into 1, it becomes 1 plus 1. If you take 1, the remaining 1. So it will become 119. If it is 35, it becomes 125. If it is 81, it becomes 171. That means 8 becomes 1 and 7. 1 is first. If it is 36, 126. Got it? If it is 73, 163. That means if it's a 2-digit number, make the first, put it as 1, put the remaining number, and it becomes, so it's very easy. Similarly, if it's a 3-digit number, more than 100, first add the first two numbers. What is 171? What is 163? What is 179? What about 102? 1 plus 0? 12. 107? 17. Okay. So this does not apply for numbers between 0 to 9. Okay. Because now 0 to 9, you just add 9 in front of it. Number starting with 91 to 99, take the 9 out of it. Okay. If the number is starting with 9, take the 9 out. 0 to 9, you just add 9. Okay, in front of it. So this is simple. So you have to practice this repeatedly so that you will be able to do. And another thing they will ask you in the exam is, this is important, is about use of Jackson's cross cylinder and astigmatic dial. There are many subjective verification of refraction, duochrome test and so many things. These are important because it may come as a short note or it may be asked in the exam. They may keep it as a spotter. They may ask you to use it. Okay. So Jackson's cross cylinder. How many of you have used it? No, don't be ashamed because nobody uses it anyway as PGs. Okay. But let me tell you, it's a very good tool for somebody who's interested in doing a subjective refraction. Okay, it's a subjective verification of sphere and cylinder. I'm going to now just quickly go through what is cross cylinder. See, cross cylinder is a spirocylinder which has got cylinders of the same strength but opposite denomination, opposite signs at 90 degrees to each other. That means if this is the cross cylinder, okay, this will have plus 0.5 means this will have minus 0.5. So what is if you want to write a prescription and make a cross cylinder yourself, okay, you just write a cylinder in such a way that it will be any number, 90. Okay, sorry, this will be plus 0.5, minus 0.5, 90. So this will be the thing. Okay, so what you do is now, this axis is negative cylinder, this axis is positive cylinder. And the spherical equivalent of a cross cylinder is always 0. So if you put a cross cylinder to any patient, the final visual acuity won't change because you're not going to add any spherical equivalent to this prescription. Okay, now how do we actually use a cross cylinder? So first is, there's something that you need to actually do it yourself. I can't really explain everything here, but I'll give you a small tenet. You can go back to your institutions and start trying cross cylinders on some patient so that you will be able to pass the exam. After that, it's up to you to use it or not. Okay, first is always refine the axis. Always refine the axis. So imagine this is your trial frame and the patient already has a cylinder at 90 degrees, which is minus 1 cylinder. Now you want to refine the axis, whether it is 90 degrees, whether it is 100 degrees, whether it is 80 degrees, you don't know. So what you do is, you put a cross cylinder in a way that the two axes of the cylinders straddle the test cylinder. So the test cylinder is 90. Okay, you straddle in such a way that one becomes 45, one becomes 135. That means equidistant from that. So you straddle the cross cylinder in such a way that this becomes minus 0.5 and this becomes plus 0.5. You straddle it like this and see whether the patient reports improvement in the vision. The patient should not be 6'6". What you do is, imagine he has minus 2 sphere correction. You change the sphere correction to minus 1.5. See that vision is 6'12". Okay, if you are given full correction and check the cross cylinder, he may not report much improvement because already 6'6". The vision has to be slightly blurred. Okay, so slightly undercorrect the patient in the spherical compartment so that he is able to see around 6'12". So that any improvement he will be able to report. So now check this, and what you do is you flip it. Flip it by 180 degrees. That means you flip it, what happens? This becomes plus, this becomes minus. Okay, so position number 1, position number 2. Ask him to compare both and say which one he saw better. The patient says, the second time, when the minus cylinder was on this side, he saw better. So then what you have to do is, you have to shift the test cylinder, to towards the corresponding sign of the cross cylinder. Where was the minus cylinder? It was on this side. So you have to shift your test cylinder, the main cylinder, towards this side. If you had seen it in the first time, then the minus cylinder was on this side. So you have to shift the test cylinder towards the minus sign. If this cylinder were to be plus, then see where is the plus cylinder in the test cylinder, and then turn it towards the corresponding sign of the cross cylinder. So that you can just turn it by 5 to 10 degrees to see whether the vision improves better. Okay, in that new axis of 80 degrees, again you can straddle it. 45 on either side. Again check. Till that, he doesn't, both the flips, both the times, he reports no further improvement. Okay, this is refining the axis. This is just a small idea, you need to do it yourself and learn. Second is power. Power is very simple. It's no big deal. You have to align the axis to axis. The test cylinder is 90, you align first plus cylinder. Then turn it by 90 degrees, align the negative cylinder. It is like changing the cylinder 0.5 that side and this side. If you align the two cylinders, imagine already it's a minus cylinder, you align another minus 0.5 of the cross cylinder, it becomes minus 1.5. Whether by increasing the cylinder to minus 1.5, does he see better? It is as good as taking the test cylinder out and putting another minus 1.5. And also if you align the plus cylinder, it is like reducing the cylinder to minus 0.5. So, testing the cylinder power is no big deal, that you can do it subjectively also. But refining the axis is something which is very important. Okay. Next is astigmatic dial. Astigmatic dial is, anybody has seen it? Anybody has it in this one? You can make it yourself. You can just go to a paint program and make one astigmatic dial and use it. See, basically it has got like the hours of a clock. Okay, it is from in the upper part only, not the full circle. It's just a dial. So what you do is, it is like this, clock hours. So again, you have to fog the patient to such an extent that his vision is around 612, not complete. Imagine he's a myope, okay? Then his fog to 612, or this correction corrected to 612. Then ask him to look at the dial, that's all, nothing else, nothing is to be put. Whichever line, okay, is clearer, you have to add a negative cylinder perpendicular to it. Imagine if these lines appear clearer, this line in the vertical meridian looks clearer, then probably he will require a cylinder at 180 degrees, a negative cylinder at 180 degrees. Okay, this is something that you have to do and learn. Okay, you have to understand why it happens by reading some theory. But I think we don't have time for that. So we'll go to the next one. What is now, see, I was just teaching you hardcore exam refraction. But now I am a clinician, so I want you to understand why this refraction is required. Okay, how it is application in our clinical practice. See, that is very, very important. Okay, unless just knowing theoretical refraction and passing exams is no good. I will ask you some simple clinical applications you have to tell me. Okay, now the patient was planned plus 20 diopters implantation in the bag. Okay, something happened, there was a PC rent, so we had to put this patient, lens in the sulcus. Okay, you have an option, inventory of lenses. The patient required plus 20. So now how much power modification you make to put it in the sulcus? You have to reduce or increase? You have to reduce by 0.5. Everybody agrees 0.5? It is not 0.5. So to pass the exam you require 0.5. But in practice it is not 0.5. Because the dioptric power of the eyeball matters. 0 to 7 diopters, no change required. You can just put it in the sulcus or in the bag. 7 to 17 is 0.5. 17 to 27 will be plus 1. This man, if you put just 0.5 correction, still he will be myopic shift will be there. So after 27, it will be plus 1.5. You have to reduce 1.5. So more the dioptric power of the lens, you need to subtract more. You understand? So this is how it is. Now imagine a patient comes to you with silicone oil induced cataract. Okay, his eyeball power is plus 24. Will you put plus 24? Patient has silicone oil in the vitreous. What eyeball power you are going to put for this patient in which we have had a silicone oil, his eyeball requirement is plus 24. what happens? If you don't have silicone oil, so the patient don't come for cataract surgery. Or, reduce it by how much? +6. How? Why? See, again there are two issues here. So it all depends how much you read ophthalmology. You can complicate the answer also. If you know too much of ophthalmology, you can say there are two issues to consider here. Number one, what biometry you have done. Okay, whether I've used an optical coherence biometry, like an IOL master or a lens star or something like that, which takes the silicone oil into consideration, or it is a normal routine ultrasound biometry. If you have done an ultrasound biometry, there is a sound wave basically which passes through the vitreous, okay, or the fluid, much faster than it travels through silicone oil. See, how we actually measure the distances in biometry is, the sound waves pass through, any reflection, any disturbance, it comes back again, so we measure the time difference. It goes to the retinochoroidal complex, comes back, so the time taken by this ultrasound sound waves is measured, and we calculate the distance accordingly, because we know the velocity of the sound waves through the vitreous. But when there is a silicone oil, these sound waves are retarded. It travels slowly, so it comes back after much longer time than a routine eye. That means the machine thinks that eye is much bigger, because the time taken is more. So it is considered as a myopic eye. So the IOL power will be reduced. What will be the IOL power? If the machine thinks it's a myopic eye, so instead of +24 millimeters, it is going to measure it as maybe 25.5. So what will be the effect on the IOL power? It will be reduced. So you are putting a +24, it will be grossly incorrect. So what you have to do to correct this? What you have to add or subtract? You have to add. So around +4 to +5 will be the addition to the IOL power that you are going to implant. Okay, and nowadays we are now using most of plano-convex lenses. There was an era where we were using biconvex lenses, where even the posterior surface was convex. If the posterior surface is convex, what will happen? Tell me. If I put a biconvex lens, the posterior surface is convex, the vitreous face, which is with a silicone oil, will go press against that, and what shape it will take? It will take a concave shape. A concave lens will be produced in the vitreous. Then what will be the effect? A concave lens in the vitreous will shift the eye towards hyperopia. So whatever lens you put, the patient will have a hyperopic shift. So there are two reasons. So the second reason you can forget only when they ask you tell. First thing is it about sound waves. What the examiners know, you should know. Okay? So there's not be a mismatch. Don't try to read too much and go past the examiner's level of knowledge. So you have to basically understand that the sound waves make all the difference. If you're using an optical coherence biometry, and what they will ask you, why an optical coherence biometry is far superior to routine biometry for axial length measurements. What is the single most important factor? No, that is one part. Silicone oil mode and all is very small part. What is the most important aspect why this is important? Basically, you are measuring the axial length in the visual axis. This is very important. Because patient fixes at the light, you are measuring from the center of the cornea to the fovea. Whereas other ultrasound machine, basically they just see what is the most posterior part. If there's a staphyloма there, the fovea may be somewhere, the fovea may be in the pit of the staphyloma. So basically, the difference is because it is not measured along the visual axis. Okay, number one. The second point is, it's a non-contact method. So non-contact method, the corneal indentation can decrease the axial length, okay, if you are pressing the cornea. Okay, so it's a non-contact method. All other things are different. You can check keratometry, you can do silicone oil mode, you can do that, this, you know, post-LASIK mode and all that. Okay, so this is something that you need to understand. And quickly we'll go through another thing they're going to ask you is, we used to give aphakic correction in the past. So what are the problems of aphakic correction? See, this you should know because once in a while you may get a patient who's wearing aphakic glasses. Okay, who has not gone through our secondary IOL process. So what are the problems of aphakic glasses? Quickly we'll go through. Number one, what is the most important problem of aphakic glasses? No, don't say that. It's a spatial disorientation due to relative magnification. That is the word to use. Because whenever we judge distances, we judge by the relative size. Okay, you suddenly look 33% bigger, you think I feel that you're sitting here. So I'll give the mic here, not there. So if I want to, there's a glass, you are putting water through the jug, the glass looks bigger, it appears it is closer. So there's a spatial disorientation due to relative magnification of objects, which is around 33%. This is number one. Number two is, on a monoocular aphakic correction, there will be this anisoconia will result in intractable diplopia. So second point is, monoocular aphakic correction, intractable diplopia because of anisoconia, which cannot be managed by the brain. 33% cannot be managed by the brain. Number three is ring scotoma, which causes jack-in-the-box phenomena. They may ask you, what is jack-in-the-box? Jack-in-the-box is you open a box and suddenly something springs up. That is jack-in-the-box. So here, what happens is 65 degrees to 50 degrees of your visual field around your visual axis is nothing. There is a dark scotoma there. So objects appear blurred outside my glass very indistinctly. They enter into scotoma. 65 to 50 degrees they travel. I am not seeing them. Suddenly they jump into my visual field. So aphakic person wearing glasses will always see things jumping into his visual field. They never come into the field. They always jump because they are coming. He thinks that they are jumping because they come from nowhere. So that's why he always has a jack-in-the-box phenomena. And also roving ring scotoma and the pincushion distortion. These are all other things. But most importantly, disorientation, spatial disorientation, diplopia, binocular diplopia, and also ring scotoma causing jack-in-the-box phenomena. These are the three things that is important. Now I told you the boom is refractive surgery. I want to know how much of refraction that you know what is relevant to refractive surgery. Okay. See now, two things that matter to you is correction of astigmatism during your cataract surgery. So the patient has astigmatism, usually it is against the rule. If it is a higher astigmatism, if you do a phacoemulsification, the only problem of phacoemulsification is what? What is the problem? It doesn't correct astigmatism. Okay, it doesn't induce astigmatism. What we tout it as a major plus point is a negative point because the patient has astigmatism. So how do you correct a pre-existing astigmatism? So what are the number 1, 2, 3, 4 the examiner wants? Number 1 is first chase the steep axis. Chase the steep axis, put incision along the steep axis. It is going to decrease it by around 0.5. If astigmatism is more, you put 2 opposite clear corneal incision, what we call as. You put another incision on the other side called opposite clear corneal incision to decrease or flatten the meridian along the steep axis. Number 3 is limbal relaxing incisions. So that's a much larger incision at the limbus, which takes around anywhere 45 to 60 degrees on a nomogram. Any nomogram's name you know? You can put as Nichamin, that is the commonest nomogram used. The last one is you can do arcade incisions. But all said and done, whenever you do any corneal incision, LRI, PISA, your incisions, arcade incisions, the patient's quality of vision is worst. Patient is not happy. You are happy because there is no cylinder. But the patient is absolutely unhappy. Why? When you touch the cornea, inside the cornea, it induces higher order aberrations of the cornea. These aberrations of the cornea is something you should know. So any incisional surgery on the cornea induces higher order aberrations. The final visual acuity is very bad. The patient's quality of vision, patient's contrast sensitivity. See, we have been doing Sneller's chart for the last 120 years. It's a 100% contrast black and white chart, which should not be used in our practice. We should be using a Pelli-Robson chart. What is that? Contrast. For contrast. So that is how the patient sees. Patient doesn't see everything black and white 100% contrast. Patient see in real life, of different contrast. So we are really dare enough, you are a brave heart ophthalmologist, replace it by Pelli-Robson, you'll understand how many patients of your 6/6 are unhappy. So similarly here, the patient may be on the Sneller's chart, but he will have, so the best way to correct a pre-existing astigmatism is toric intraocular lenses, because it corrects the corneal astigmatism in the IOL plane. It spares the cornea. It does not induce higher order aberration. So the best way to correct astigmatism, it is not a market-driven strategy. I have not been sponsored by any toric IOL companies. I am saying from my experience, the patient will be very happy with a toric intraocular lens. Similarly, presbyopia is the biggest complication of cataract surgery. I told you the next boom. So cataract surgery can be an event to correct your presbyopia. So how do you correct presbyopia with cataract surgery? Don't say accommodative. No, don't say multifocal also. What is common man? I'm a common ophthalmologist. You should see, most of the examiners are not very high-fi, high-volume cataract surgeons. Okay. So make monovision, number one. That is the greatest answer. First is, sir, let us correct one eye emmetropic for distance and one eye, okay, little myopic so that he can see near without giving glasses. So monovision principle, making one eye myopic, okay, to see intermediate distance would be a good idea, okay, which without disturbing binocularity. So monovision is number one. Number two is, okay, leaving some myopic astigmatism uncorrected. Again, it's a monovision principle only. Number two is, multifocal lenses. Multifocals, again, two types, refractive and diffractive. Okay, refractive is basically there are different zones of power which will basically have the patient. The problems of refractive multifocals are they are pupil dependent, but the advantages are they cause less decrease in the contrast sensitivity and they are good for distant vision. Whereas diffractive, they are pupil independent, but they cause a lot of loss of contrast. Okay, so you can actually combine both in the dominant and non-dominant eye called mix and match also. Okay, that's
Dr.
about that. The
Prasad,
next is accommodate.
Dr. Prasad,
Yes, sir.
you have another 30 seconds.
30 seconds? Yes. I thought 30 minutes. I'll take 2 minutes with your permission because I'll cover LASIK and finish it off.
I told you in advance.
Okay. Santosh sir, LASIK is their bread and butter, please. You're okay with 2 minutes? Huh? Okay. So this is accommodative lenses where there is a forward shift of the optic within the eye. Okay, what is the most commonly used accommodative lens that you know? Crystal lens from Boston Lamb. Okay, the last one is about LASIK. We'll finish with LASIK because that is going to be everything for us tomorrow. And don't think that it's again as somebody who is trying to make materialistic ends out of ophthalmology. LASIK refractive surgery is the biggest thing that you can do to a patient. Somebody who is being basically, under the burden of his spectacles, okay, will be very happy if you do a good surgery very scientifically. Okay, there are lots of patients. India has 1.3 billion patients. Okay, 1.3 into 2, so many eyes. So refractive surgeries are abundant. Okay, 15% of refractive errors, you have lots of patients to treat. So please get into the groove, start working on refractive surgery. Okay, you should know the basics well. So I'll tell you one simple example. A patient comes with -4 myopia to you as a surgeon. Okay, ask you, you want my glasses corrected. What will you see first? 1, 2, 3, 4, quickly.
So we look for the cornea.
Cornea topography, okay. Corneal thickness, okay. Fundus, okay. All that, see, first number one is see how much is the refractive error, -4. What is his corneal thickness? Corneal thickness is 500. Okay, can I do LASIK on him or not? Yes? How many say yes? With only these two parameters, 500 microns thickness and -4 sphere. हाँ? नहीं करते? अरे पैसा भाग जाएगा, इसके पास जाएगा वो तो करेगी, 400 से भी करेगी. See, that's what I'm. So these are totally confused about it. I'll try to oversimplify things for you. Whenever to see the feasibility of LASIK procedure, okay? You know there are definitions that you should understand. LASIK is laser-assisted in situ keratomylosis. Whereas LASIK, L-A-S-E-K, is laser-assisted subepithelial keratectomy. Okay, where you basically remove the epithelium with alcohol and do a surface ablation. Then you want epi-LASIK, where you go to microkeratomy, specialized microkeratomy to remove the epithelium just like LASIK, so that you save the thickness of cornea. Okay, that is epi-LASIK. And you have PRK, where you just remove the epithelium whatever way and you just do a surface ablation. You got a trans-PRK, where even the epithelium is removed by the laser without touching, so no touch surgery. Okay, there are various ways of, they got corneal inlays and so many other things that you need to read up. So we'll quickly finish. How can we understand whether the corneal, this is feasible or not? Number one is, first see the amount of refractive error. See, cornea is 500. We are going to take a 130 micron flap. So 500 minus 130. Okay. 370. See, some mathematics are required to earn money. Okay. You should remember this much of arithmetic. I want to keep 300 microns of cornea intact. My residual stromal thickness should be 300. So 370 minus 300. 70. Then comes the question, what you should know, what you are not taught as postgraduates is, you think every machine is same. No. Every machine is different, highly different from each other, because ability to change a dioptric power, how much of cornea it consumes. Each machine is different. Imagine my machine takes 15 microns of cornea to correct one diopter. That means how much of power I have now? 4. 4 into 15. 60 microns I can dispense with. 60 is there? Yeah, it was 70. So I can completely correct in this case. Imagine the same guy comes with minus 8. Same guy, 500 microns, minus 8. Now I have only 70 microns. I can only correct 4.5 diopters. 3.5 will be residual. Now what will you do? There are two questions here. Now what you can do is, number one, you can try to change your technique. From LASIK, go to PRK. So PRK, you are basically, see 130 microns, 60-70 microns only epithelium and Bowman's. Another 50-60 microns of stroma which comes as a flap, you can ablate. So we can add another 60 and we can probably change the technique to PRK. So this case would be a case for PRK, not for LASIK. Number two is, change the optic zone. If you reduce the optic zone or the treatment zone, okay, you can correct, probably with an optic zone of 5 millimeters, my machine takes only 10 microns per diopter. That means you have 70, I can correct up to 7 diopters easily. So if you reduce the optic zone to 5 millimeters, I can correct more. But there is a hitch to decreasing the optic zone. If you decrease the optic zone, you should always see what happens to his pupil at night. Imagine his pupil is 6.5 millimeters at night, what we call a scotopic pupil diameter. Then 1.5 millimeters of the area which is treated, that pupil will be much bigger than the treatment zone. He will have a lot of photic phenomena, glare, halos, and all the problems at night. So the treatment zone has to be smaller than the scotopic pupil. So you have a limitation for that. You understand? You cannot reduce the treatment zone beyond a point because it cannot be smaller than the scotopic pupil. So if scotopic pupil is 4.5 millimeters, imagine. Then you can aram se go and decrease the optic zone and do LASIK. Okay, if his scotopic pupil is 6.5, you can't do LASIK on him. You can't reduce the treatment zone. So what is important is total power. Okay, you have to see the corneal thickness. See what is how much of correction your machine gives for so many microns of cornea. That is another thing. What is the treatment zone and what is scotopic pupil? These are the things that you need to understand. If you can't do LASIK, turn to PRK. If you can't do PRK, turn to phakic IOLs. You can implant a lens, okay, between the iris and the lens called phakic IOLs, so that you can correct, and that is the best way to correct a refractive error theoretically. Because you are basically messing up the cornea, the lot of higher order operation induced, patient will have a very bad quality of vision in LASIK. But with ICL or phakic IOLs, you will have an excellent quality because cornea is not touched. Okay? So lastly, phakic IOLs will be the way that we go ahead in most of the cases in future. So this is the way you have to go. And finally, what you can do, very high myopias, you can remove the lens, okay, so that you take the converging power. Minus 18 diopters of myopia will be emmetropic after lens removal. You don't have to replace it with anything else. So, clear lens extraction or refractive lens exchange can be the option for very high myopias. Okay. So, I'm really, indebted to AOS, Dr. Santosh and all the people involved in this program for giving an opportunity, and for all of you finally making it a grand success by keeping quiet and allowing me to take little extra time also, injury time. Thank you very much.